I requested Ravi for a few minutes, and I promise I'll keep it brief, and that's sort of why I didn't get up on the stage. I just want to put in a plug for what Ravi is doing here, and also to tell you a little bit of the context in which we've been thinking about innovation and services, and also put in a plug for another conference that ICLAC is going to be doing soon. So let me just sort of go through all of these. When Ravi came here a few years ago, we really started thinking about goaded primarily by IBM, but really a lot of industry to say who told us it wasn't the cool new technologies that were making money, but it was really the services that you built on top of them. And so we really needed to think about a science of services, as a science of scalable services. And certainly for a School of Engineering, which has been a tech push entity, to really not just think about technology, but then the services, really brings in a very rich ecosystem of problems, because once you start thinking about services, there's social, legal, economic, business interests which really do need to be brought into the equation. So that's a little bit the genesis of this Service Sciences Management and Engineering program that Ravi talked about. Very quickly, though, in this SSME, we realized that the biggest sort of cottage industry in healthcare was health services. The biggest and largest, I think, the largest sector, of course, of the economy, but a cottage industry sector, nonetheless, was healthcare. And just in terms of this evolution, this was about the time that Andy Grove, who was former CEO of Intel, came to Berkeley, and he gave a wonderful talk, which was about the time that he inspired Intel to create digital health. It was called Shift Left. Out here at Berkeley, shift left means something different. So needless to say, the talk was sold out. Here's a icon of capitalism who was talking about shift left. But what he was really talking about was a mindset. Where he said, think about two axes. The x-axis is sort of the cost of healthcare, and the y-axis is sort of a comfort level, how comfortable you are getting the health care. And he put emergency rooms over on the right, really expensive and really uncomfortable to be in. And he put home care and telemedicine as low cost and really comfortable at home. And to him, shift left was, his agenda was, let's use technologies. In this case, he wanted Intel to create digital health to be able to pull together technologies that shifted us left. And I think this was the premise behind which he founded Intel Digital Health. And of course, one can argue a little bit with the premise, but let me not argue with it. But I think to first order, this premise of shift left has within it, built into it, really a lot of wonderful ideas. It has this idea of telemedicine coming of age, as the use of wireless technologies, the notion that you can think about electronic medical records, to be able to and customization of healthcare, continuous monitoring, customization of treatments, pay models which are based on sort of billing systems which are closer to sort of getting people to pay for services that they actually receive, rather than some notional person receiving, notional average person's payments, and so on and so forth. He complained to me a little bit more recently, just a few days ago, that he felt that in Intel Digital Health, of course, at Intel, they as soon as they launched it, they immediately found out that there was tons of hospitals that wanted to buy their servers. I hope I'm not going to offend anybody from Intel in this room, but it was actually a pleasant statement. So what happened was that they had this gigantic market opportunity that came to fruition, and so in some ways that really detracted from looking at these more complicated problems. And of course, Intel Digital Health is now re-gearing to look at this. About the same time, so I'm just telling you this because Andy Grove is an alum and somebody who advises the college on directions to go. Another alum, Paul Jacobs, the CEO of Qualcomm, sort of said, well, there's a great convergence happening, and maybe you already heard this from Ravi. Every widget has chips and processors, and nowadays multi-core processors. Every chip has a radio, and so of course Qualcomm sees a future where there are 1,000 radios per person. So what do you mean by 1,000 radios per person? You know, to a lot of you in this audience know, you know, even the average cell phone has about 8 or 10 radios on it. And that's what you can buy today. And we really expect that between RFIDs and smart sensors and you can have every Band-Aid with a little transmitter on it, and that's not a fiction. You know, it sounds like a joke, but you know, it's almost here. I think that you'll really have. Sorry, the wireless interfering with the on cue here. So he started saying, well, you know where Qualcomm needs to go is to really start thinking, and you know, Paul Jacobs is, some of you may know him, he's a very fit, athletic guy. He always has been. And so to him he said, you know, I'd like us to start keeping track, so health maintenance is really a big push. And Qualcomm has decided that they're going to start using wireless. And none of these are rocket science. That, you know, really start thinking about monitoring. And his big thing, which I think is very hard to do, is he feels that calorific consumption is not a good indicator of good health because really people have different metabolic rates, and metabolic rates change from time to time, and really you need to index your consumption to what you need to burn up. And so he really wants his wireless widgets to have assays and other techniques for actually trying to determine you know, the rate of consumption of the calories as part of his health maintenance. That's pretty hard, as a lot of you in this room know. And about the same time, I'm just telling you sort of about the convergence in my own head, and I'm going to really promise to get off the stage here. Vanderbilt, the medical school at Vanderbilt, started doing its health portal called My Health. And, you know, it's a live portal, and amazingly, the Vanderbilt Medical School has been pretty open about letting us play with what is really a live portal. You know, they add 10,000 users a month, and so it's actually a growing portal. And the concern, of course, the issues for them, but the reason they let the unsophisticated, why am I getting an echo? Can somebody turn down the, is there an AV person here? Okay. Yeah. Is that, you know, security and privacy concerns are really a big bugaboo in electronic medical records. And really, till we fix what we mean by anonymizing data, what you mean by derived data, what you mean by things that you can do, there are really pretty serious concerns about and who you notify, how people want to notify. You know, when you think about elder care, the older population frequently doesn't want children to be notified first because, you know, they'll worry is the most frequent response. And so, you know, I think we really need, there's a lot of wonderful technical problems underlying each one of these. And the issue really has been to have a clear strategic vision about the kinds of things that they can do, and really to then populate that strategic vision by ways of delivering it at low cost. The premise of technology, you know, everything that happens in a school of technology is about democratizing things which were hard to, about things which are expensive today. And that's the central premise of a school of technology. You know, the original cell phone costs, the first of a kind of a widget costs hundreds of millions of dollars to build. But then people seek big markets, and people seek to reuse this in many, many places because the central premise is to cut the cost down. So while we are thinking about an industry sector where the growth of costs is so out of control, I really think that this mindset of the technologists, and this is partly why Andy Grove is saying shift left, because he had absolute faith that the role of information and communication technologies, for the specific thing he was thinking about, is really to be able to drive down cost through volume. And of course, the route to doing that is to have a very clear model of the services. And you know, it's no secret to everybody in this room that I think it's just really the biggest problem confronting us as a nation, and certainly internationally. I'm very pleased to see the co-sponsorship with Denmark, and I know there's people from Finwell also here, and you know, this partnership with both Denmark and Finland has been really pretty wonderful in this regard. So I'll conclude by saying you're looking at some pretty knotty problems, But let me assure you that the captains of industry are all right there pushing their companies to be able to push down the costs of the technological solutions that you demand them to do. And when I talked about democratization, when you make things personal, you know, the other thing that Andy Grove, we were talking, everybody's talking about EMR, right, the electronic medical records. So Andy Grove is, you know, as you may know, he fled communism in Hungary and so on. So he said, don't ever use something which sounds like centralized authority, EMR. So always call it PHR, for personal health records. You know, and the central premise, again, of these information communication technologies are by personalizing the technologies. That's part of the democratization. And that's part of what drives down the cost, too. And it also makes it a model of payment where you take responsibility because it's personal. You know, it's not some cloud out there that's paying for these services. Okay, so the last thing... am I out of time? And this is a little bit of a personal plea. You know, at Berkeley we've started 2 years ago what's called the Blum Center for Developing Economies. And it is, again, based on the premise that really technology plus service solutions, as well as the right financial models, can help people work themselves out of poverty. And, you know, I mean, if you think about this, it's a no-brainer. You know, 1.1 billion people don't have access to clean water, 2.8 billion people don't have access to sanitation. Cook stoves, which are used in large parts of the world, are tremendous implications on respiratory diseases and in terms of deforestation, creation of vectors for new kinds of diseases. You know, when people talk about climate change having a disproportionate effect on poverty, that's one of the things, right? You know, it leads to deforestation. Deforestation, people use cook stoves, particulate matter, carbon monoxide, higher incidence of respiratory diseases and so on. So, looking right at here, Christina Robbie is one of the stars of this, and she has been pushing the notion of wireless technologies as a way of delivering healthcare in the developing world. And she's worked in Kenya, Uganda, other places, really, about emergency services being delivered. Bodas are these, it sounds like a motorcycle. It is sort of a motorcycle taxi there for delivering emergency care using wireless technologies, output-based aid. So we had a little workshop on it last week on Friday, which is called Global Healthcare Delivery. And the word global, of course, refers to what you can do in the developing world. But of course, when you start thinking about the developing world, you know, really a lot of the solutions that you think about, the reason they're good solutions for the developing world is because we prototype them here and use them here. There was one irreverent participant from the same school as Christy who said, you know, I'm not Mother Teresa, I'll only develop solutions if they'll also work out here in the developing world. He said it a little bit tongue-in-cheek. And Christy, I'll let you figure out who that might be. But I think here that when you start thinking about the developing world, and that's where I was going with this, and delivery of services to the developing world, that really keeps the cost in perspective. And people are willing to pay. Another wireless solution, which Christy's colleague Eric Brewer has been doing, is you know, telemedicine for cataract examination in South India. So he has these little huts which are connected on 802.11. 802.11 is just the Wi-Fi technology. So he can get Wi-Fi technology to go over 50 miles, you know, line of sight, basically, as far as you can see. You know, once you start getting over 200 miles, the curvature of the Earth actually gets in the way of being able to see. But because of that, he's been able to get people. The Arvind Eye Hospital is his partner in the south of India, and you know, he's been able to show that, again, using wireless technologies, you can get people. You can provide a service model where people out in the villages, local people out in the villages, can get emergency medical care. And it's the service model. The 802.11 technology, the cell phone technology, you know, the Nokias and the Qualcomms and the Motorola's, they will push this relentlessly, and the people are willing to pay. The future really isn't a $100 laptop. The future is what you can do around these wireless technologies. And of course, you can, with the power on them, you can start putting all kinds of medical records and so on. So, you know, the developing world is actually a pretty interesting laboratory for trying out solutions that we'll bring back here. And surprisingly, you know, it's not a flow-down model. Things that you develop in Kenya, Uganda, etc., actually have a pretty non-trivial impact. I don't know if Robert Morris talked about that at IBM, because, you know, part of what IBM also feels is that by thinking about solutions for Africa really results in big messages for them out here in the United States. So, okay, so I think I've outstayed my welcome. I'm really delighted. I'm going to sit in the back and listen to the conference. Thank you very much. And I'll return the thing to you.